Welcome everybody from all around Australia. My name is Neeta Oakley and I'm a social worker with Diabetes Tasmania. In my social work career, I've worked largely in the field of health, spending over 5 years in an acute palliative care ward, and I'm now working in a clinical diabetes team. I've also had the benefit of working with students as part of the social work field education team at the University of Tasmania and being part of the physical activity research team at the Menzies Institute for Medical Research. All of these experiences have greatly informed my approach to working with people with diabetes. This webinar today will provide an overview on why a social perspective is important when working with people with diabetes. I'm aware that I'm talking to a broad range of health professionals today, so I've decided to share some practical, simple tools that support a social approach to diabetes healthcare that can be used by any type of health professionals and even in brief interventions. I will also ask you at certain points throughout the webinar to write down some responses, so grab your paper and pen. Research tells us that we don't retain very much of our professional development at all, and that the act of writing can solidify learning. Before we dive into it, I know not everybody has worked with a social worker before, so I wanted to give you an overview of what a social worker does in a health context. Social workers have a governing professional body, the Australian Association of Social Workers, and we're guided by a code of ethics. Social work is a practice-based profession, and we're an academic discipline that promotes social change and development, social cohesion and empowerment of people. We have principles of social justice, human rights, collective responsibility and respect for diversities. That's all very central to social work. So we engage both people and structures to address life challenges and enhance well-being. So we really look at the person in their environment. So what do social workers do? It really varies, but here's a bit of a list. So we do direct interpersonal practice, so direct client work, casework, some people are counsellors, group work, so we might work in a diabetes support group or a drug and alcohol rehabilitation group. We do a lot of advocacy, so workplace discrimination advocacy due to diabetes stigma. A lot of social workers have been involved in the National Redress Scheme for sexual abuse in institutions. We do community work, and a lot of our social workers are out there now in flood areas, and we're working with communities during the fires. We're very involved in social action, so trying to get change. You might have seen that in the refugee space, or we might work with Centrelink to allow terminal illness payments to come through easier for clients. And a lot of social workers work in policy development, so they might be behind the scenes as a political advisor or manage the NDIS, as well as education and research. So the key factor in all of this, all these contexts, are that social workers maintain a dual focus on both assisting the individual and at the same time identifying and addressing any external issues that might impact on the individual or group wellbeing, any structural issues that might create inequality or discrimination. So there's that dual focus. Social workers view health through a biopsychosocial lens. So I'll give you some time now to look at this image. So social work has a strong focus on the red circle, the client's social context. And this covers aspects of the person's life, such as who are the key peoples in their lives, who are they linked to in society, what's their socio-economic background, what resources are available to them in their community, whether it be rural or urban, what's their health and digital literacy like. So the whole person's context is taken in consideration in this model. So we're also looking at biological and psychological influences. So we're looking at all three at once with a particular interest in the social context in terms of practice. For example, when I work with a client, I'll document my initial consult information sort of in these categories. So I'll record their biological experience, they're in the blue sphere, their illnesses, whether they're on insulin, antidepressants, and how onerous is the medication regime. And I'll detail such things as they might have emerging neuropathy in their feet and be at risk of complications. I also will collect information from the green sphere about their coping strategies in the past, any past traumas, if they had a history of domestic violence, for example, and the importance of their faith to them if they talk to me about that. I find out a lot about the red sphere, who's in their household, their life, who's in their health team. They might be in an isolated community in the northwest of Tasmania with limited services and receive a disability support pension. So all this will guide my approach to working with people with diabetes, and I'm sure a lot of you taking all of these into your assessment as well. Furthermore, when working with people with diabetes, we'll be looking at their psychosocial well-being at 2 levels. So the top arrow will be looking at the impact diabetes might have on their life. Diabetes distress, depression, self-management, self-care fatigue, their functionality and any complications, disordered eating. And then at the same time, concurrently, there's the impact of multiple psychosocial problems that will influence that person's ability to manage their diabetes. So the psychosocial could be their financial ability to regularly see a GP, or their ability to follow a medical routine in a chaotic household, or how the stress from COVID lockdowns what it might have on their blood glucose levels. So the effects, what's affecting their diabetes. So with that dynamic in mind, we'd be considering the health system, the environment that the individual is in. So for example, we know that the Tasmanian primary health system, it recognises itself, operates with a siloed approach. So it's currently orientated towards single need, single problem models of service delivery. This doesn't always meet the needs of people with multimorbidity who require complex care, whether that's medical, social, their mental health. So compounding this, there's been a phasing out of case coordinators to assist clients to navigate this system, and we have a role here. It can also be helpful when having a social perspective on diabetes, to reacquaint ourselves with the social determinants of health, as shown on this graph. Have a look now. As you know, social determinants of health are the non-medical factors that influence health outcomes. So the economic and social conditions that influences people's health. We know diabetes is more prevalent in disadvantaged communities with poor social determinants of health. People in disadvantaged communities are vulnerable to the link between diabetes, psychosocial problems, and poorer health outcomes, including what we're all interested in, poorer mental health. So there's growing recognition of the need to address these social determinants of health within the clinical setting, so what we do, and to provide social support within the diabetes self-management. People in disadvantaged communities are vulnerable to the link between diabetes, psychosocial problems, and poorer health outcomes. If you have a look at this slide, I've highlighted in the middle that diabetes prevalence increased with level of disadvantage from 3.4% to 6.9%, which is quite a lift. So this disparity exists for people in low socioeconomic groups in terms of diabetes prevalence. And that brings us to looking that social support provides positive impacts on the health and quality of life of people with diabetes, and that international guidelines recommend psychosocial support now as integral to team-based, patient-centred diabetes care. So when working with people with diabetes and all chronic conditions, actually, research shows an integrated multidisciplinary approach is the gold standard for person-centred care. I'll give you a little bit of a background. So Diabetes Tasmania knew this evidence, and they decided to diversify its well-established clinical team of diabetes educators and dietitians, and they added me, a social worker, and a nurse practitioner. And I want to share with you about the social work pilot program that I developed here and what our team has learned about integrating a social perspective into our organisation. To better understand the needs of people with diabetes, as well as the organisation and staff that I was coming into, I began my pilot study by conducting some qualitative research. Before I could design a social work service, I really needed to understand the gaps and the needs, the opportunities, and to ascertain how staff were currently working with complex clients. And through these, I did a variety of qualitative research. One of it was some interview, a 1 hour long interview with 9 clinical staff individually. And then I did some thematic analysis from that. And 4 themes emerged. And one of them was the common psychosocial issues reported by clients to their workers, ways they thought the social worker could assist people with diabetes. I asked whether dealing with psychosocial issues challenged the health professionals to work outside their scope of practice, particularly around mental health, and the impact the role of the social worker service may have on current organisational practices. So it was really interesting. The clinicians, not surprisingly, mental health, which we'll hear about today, was seen as the biggest psychosocial issue that people with diabetes faced, and as well as access to services after that and financial issues. So I'm going to read some quotes from our wonderful staff from these interviews that just describe the experience of our clients so poignantly, and they might seem really familiar to you as well. I think many mental health issues are connected to diabetes distress, and there is a lot of anxiety and depression as well as overwhelm all across age ranges. Fear of complications is really high. They might have had a family member go blind or have an amputation. I get the whole spectrum, from diabetes distress to acute mental health conditions. People feel burnt out, especially if you're already a carer for another person. So I'd appreciate it right now if you could jot down 3 or so mental health issues that you see regularly in your clients with diabetes. I'll give you a bit of time. So 3 also mental health issues that come up. We know that mental health challenges, such as diabetes distress and depression, are really common amongst adults with diabetes, and that poor mental health is associated with a reduced quality in life, increased healthcare costs for the individual, workplace and the government, diabetes-related complications, and just in general, suboptimal self-management of their diabetes. So often the mental health issues that you just listed yourselves are intensified by the barriers the person with diabetes experiences with access to services. So the second most common psychosocial issue for people with diabetes was access to services that our clinicians reported. And as I read from these quotes, we can imagine how these barriers compound a person's poor mental health. Some people don't go to their GPs for various reasons, whether that's based on a very bad experience or the cost. People feel isolated in their care. I find it challenging where to send them. Things change, there are so many services, it's a minefield. They had no idea they were eligible to get care in the home, and they couldn't cope alone. The third most common psychosocial issue for our clients centred around financial distress. They said there are multiple layers. A lot of it is socio-economic, and the Northwest Coast has a high incidence of unemployment as well as a higher incidence of diabetes. Some people are illiterate. The problems are huge. Social issues, dysfunctional families, a lot of financial distress. Paying for services is the big one. One couple were shocked when someone finally told them they could get subsidised travel. They really weren't attending appointments because they couldn't afford to get there. So again, we see how this can add another layer of pressure that can really burst the pipe on the mental health of people with diabetes. So in response to the data collected from my research, the social work pilot program began, and it included statewide direct client support, mainly via telehealth. It included peer consults. So these are formal or informal consults where the staff member and I discuss a person they're working with, and together we use our different professional perspectives to find solutions or alternative ways, pathways to work with that person, discuss services. Sometimes it's in the corridor, sometimes it's over Zoom. It just depends on our team. I also highlighted my need to work in strengthening partnerships with other organisations to better support people with diabetes. And I work quite hard to add a social perspective to our own internal service developments, whether that's contributing in our editorial to GPs and pharmacists, looking at our own internal processes, looking at the education we receive, and making sure that there's psychosocial elements. So the intention was to provide a multi-pronged approach to person-centred care and to address the individual as well as to contribute to the organisational change here. So here are some things that I've learned here at Diabetes Tasmania. Think teams. Think teams for our clients, think teams for yourself as a professional, and teams for our organisation. So pictured here is my own statewide team at a team development day in Campbelltown, and we're proudly showing off our artwork that we did as a sort of fun exercise together. There were lots of laughs. So we know that person-centred care is best provided when we address the clinical and the non-clinical problems at the same time. So someone's medical health, and then there's social and personal care. So one approach to doing this is to commit to thinking in a team's perspective. Whether we work in a team ourselves or as a solo practitioner, we can still utilise this multidisciplinary approach to our practice. And when a multidisciplinary team is not possible, we can increase that interdisciplinary support for a client through expert referral, which I'll talk about further, to services and practitioners that we collaborate with. And we can keep on expanding our professional perspective by engaging with networks such as this one, and organisations where different professional perspectives are shared. So what do I mean when I say we can help our client build a team around themselves? So we can prepare our client for the almost certain ups and downs of a chronic illness by assisting them build this team. And I kind of think of it like this. When I was a school social worker, I used this protective behaviours tool, my network hand that you see here. It allows children to identify a support system that they can use if they need help. So on each finger, we name a person who listens to me, who believes me, and does something to help me. So often it's used as a tool for giving a child an action plan for when they're not in a safe situation. However, sometimes I use it a lot to simply open a conversation about the key people in the child's life and how they can support the child's health needs. I now do the same inquiry with adults with diabetes, except with no pictures and via telehealth. I explain that having a chronic health condition is complex and that they'll get the best health outcomes if they have a good team around them. So I ask them who's in their team currently. I might discuss and document that. We think about who else might be good to add. And we aim for a mix of professionals and friends and family. But many people have a very, very small team, 1 or 2 people, and we work together to increase that. I have my own professional team network that I can count on my hand, and it changes at time but retains a few core people. There are a few people from my current workplace who I can flesh out work or client dilemmas with, an old social work buddy from another workplace who I can really let loose around, my social work supervisor, and a friend who was a psychologist and understands my work as well as my personal life. So although simple, it can be quite a new concept for a person with diabetes to think of what a team around them looks like, to even know that they deserve one. So if you're socially isolated or have had very poor health care experiences, it's even more so. Right now, as a health professional, if you want to jot this down, who can you put down as your team? You can trace your hand or name your professional support network in your mind as you touch each fingertip. You can do your personal or a professional, whatever comes. And it doesn't have to be 5. All right. So helping a client build a team. Sometimes their team is very basic, even more basic than the network I've created on this graph. We might start by educating them. It really is the best health outcomes, that continuity of care is the way to go. And for a person with a diabetes, this might start with a GP. My clients often reply that they can't get into their GP when they need it, and that then they'll have to have an appointment with a GP that they might not even know. So I really encourage them to be proactive with their GP and to book in a regular appointment, say every 4 weeks for 4 months in advance, with the GP that knows them best. They can always cancel if they don't need it with a chronic illness. Something usually crops up. I suggest they buy an exercise book, if they're literate, and write down the date of the appointment, the name of the practitioner, and any questions they have when they go into a consult. They can take that book to the appointment and then write down the health professional's advice, or if literacy is an issue, they can take a photo and get the GP to sort of draw a diagram of the advice. Often another person on their support list can be someone they might not have already identified as part of their support group, but it could be like a domestic cleaner who comes as part of their aged care package, someone who sees them in the home, and these can be really important relationships. But this is still a really a very small support system, and there are no non-professionals. They're all paid. There's no non-paid peers. So over time, and it can take a good while, we might assist our person with diabetes to grow their team. This might include a friend that they trust to attend a medical appointment with them. It might be a walking group that we've encouraged them to try, and then they now socialise with these people in their local area. And it could be a psychologist that you found for them that would bulk bill. Building teams often requires expert referral. It requires you to build bridges for your clients so it's easy for them to cross when they're at their lowest. So just looking at the Ryu Bridge pictured here in China, it gives me a sense of overwhelm. And I think approaching new health services or health professionals, even new social situations, can feel like this for a lot of people with diabetes. So we need to help them cross safely. And referring it's assessing not only what service might truly assist that person, but ensuring that it happens. What's the wait time? What are the out-of-pocket costs? Can they actually afford it? Are they confident to self-refer? So many referrals fail. I think over 50% of the time when I follow up with a client after I've made a referral, it's fallen through, even though I was onto it and the client was keen. Or people leave the doctor's surgery and then they find with their recommendation and then they find out the cost or the wait list time, or was scared off by a busy receptionist and they just drop out. So it might require really checking in, calling ahead to give a good history and to make a connection with the new health professional, emailing them to update you on how it goes with the client's permission, of course. And it's all time consuming, I know. It might require checking if the referral actually got through the administration system. Technology can fail. Online forms go into the ether, faxes get put in the wrong tray, services get busy. So with that, in that context, referral systems work best with agencies. Our referrals to agencies work best when they are well-grooved, well-oiled from use. So on this screen is our health services directory for Diabetes Tasmania, which we add a lot of our well-oiled referral agencies to. So our interagency affiliations have been established with key services such as the Royal Flying Doctors, Services Australia, NDIS connections, but also private psychologists who bulk bill or who specialise in chronic conditions, telephone counselling services that are free. So this has allowed for more tailored referrals and rapid access to services for people with diabetes. We learn who we trust to care for our clients and we establish strong bridges with them. However, with some groups of people, just getting onto the bridge is a huge challenge. 55% of my clients are men from disadvantaged areas in Tasmania. And men, especially older men, often wait for an acute phase of illness before seeing their doctor. This is reflected in the low MBS statistics for men seeking preventative care, including preventative mental health care. So when it comes to mental health, diabetes can be a useful way in to talk to people about the causes of stress and then to point them to appropriate supports. It's important that men or people with diabetes are educated that repeated episodes of stress can lead to increased blood glucose levels, and that this can then add to the person's stress and lead to further hypoglycemia, a toxic cycle. So reframing stress and mental health and including questions about it as part of the normal diabetes cycle of care can be an effective approach with men who traditionally resist mental health support. Prevention is the key, and we often know when it's time for a client to have a referral to a psychologist, as it's usually a more acute mental health situation. But we can really hesitate to make a referral for low-level anxiety or depression or overwhelm or whatever's distressing our client. A psychologist at this stage is not the only option, though it might be very well placed. Having a host of offerings on hand, such as free programs doing preventative mental health care, can be an excellent asset for any practitioner and any organisation. So to introduce this preventative mental health care to a client, I'll normalise the situation, such as I might say to them, so you're saying you're feeling overwhelmed by everything that's going on, and you mentioned the word anxiety. So many of my clients statewide experience that too, and it can be really effective to attend to that as early as possible so it doesn't grow too big. Did you have any ideas of what you think might be helpful? Or are you up to trying a program that I know about? And then I might refer to a low-level program that we have that we know is going to work for that person to boost their mental well-being. So one of these is Mindstech. It's a national program, free for Tasmanians currently. Thank you, Primary Health Tasmania. that uses cognitive behaviour therapy to help people learn practical strategies for handling stress, low mood or anxiety. So clients get allocated really quickly. We can get them seen often within a week. And then they have 8 weekly 1-hour sessions over the telephone at a time that suits the client with a mental health care coach. Primary Health Tasmania actually also funds Mindfulness Australasia to provide free mindfulness courses to Tasmanians, and this can be a great skill for people with chronic illness. And as this group will already know, exercise programs, social groups and volunteering can really benefit mental health, and research shows that people who exercise regularly have better mental health and emotional well-being. There are lots of ways that exercise can benefit your mental health, including its effect on chemicals in the brain, such as serotonin, stress hormones and endorphins that change when we exercise. So I regularly refer to the exercise treatment program, which you can see on this slide, another free program that we can access. So I'm just amazed by how much more engaged people are after doing this with their diabetes management, and as well as a raise in their mental well-being. And they keep on seeing exercising in groups as something they want to do in their futures. I work with so many people who are isolated in our community, who might just leave the house for shopping and medical appointments, who don't have friends, or may not even have told their family they have diabetes. So stigma is rife. But we're social beings. We know from research that loneliness and disconnection from others is detrimental to our health, especially our mental health. We've spoken about building a team around our client, and it can be powerful to have an even wider approach to relationships, encouraging your client to be a part of a wider community. Simple encouragement on how to do this might just start with encouraging them to visit the same cafe for a drink twice a week. It is often not too long till they're greeted as a regular and a local. And this can enhance a sense of connection and build a bit of confidence to then join a more formalised group, or just to be out in the community, leave the house more often. Provides a wonderful safety net community, sense of human connection, and provides what I call social medicine. Being part of a community gives meaning and purpose, which we know, looking at this graph, is a key element, as well as social connections to good mental health. So these are I've just gone over some very simple ways to orientate your practice and your clients towards a social perspective on health that really can impact their diabetes healthcare for the better. In conclusion, a post-social work pilot staff survey found that the biggest benefit of the social work service was an enhanced team approach to diabetes care. So the internal benefits reported by staff include improvement in the quality of a multidisciplinary approach to individualised care, improved clinician knowledge of services and referral pathways for complex clients, and better linkages with other services. Embedding a social perspective into our organisation has improved the quality of clinical support delivered across the state. And combining all our skills and professional perspectives, Diabetes Tasmania has seen how it can better attend to a fuller spectrum of the person's life and health. Thank you for listening today, and I'm really looking forward to answering some questions very soon. Thank you.